So who's at risk for opioid use disorder? This is an important thing to consider whenever you are thinking about initiating opioids for a patient with pain or another condition for which it's indicated. The literature suggests that somewhere between 3 and 19% of folks in chronic pain populations will have abuse or addiction. And the known risk factors are typically the same ones we see in the general population. So those who have past substance use or either current or lifetime history, those with a strong family history of substance use disorder or legal problems. Interestingly, heavy tobacco use is often a clue, and those that have psychiatric comorbidities like depression or anxiety are at higher risk of developing these problems. And to think of this in a formal sense, there are risk tools that are available. This is an example of one, the opioid risk tool, which gives a score. So you get points if you have a family history of alcohol, illegal drug or prescription drug misuse. Additional points if you have a personal history of those, if you're of younger age, women with a history of pre-adolescent sexual abuse, and those that have psychological disease, particularly ADHD, obsessive compulsive disorder, bipolar schizophrenia, and then depression. You get a score, and this sometimes can be helpful in determining who is at risk and who you need to watch closely. Again, it's often a relative contraindication if somebody truly has pain and requires opioid for its management. This will sort of go into your calculus of risk and benefit. Like everything else in medicine, whether or not you start an opioid is a function of what you think the potential benefit will be for the person in terms of function versus what the risk is. And hopefully these tools and thinking about the evaluation of their risk for coming into problems with addiction, that will help you think about the risk. So in evaluating folks for their risk of substance use disorder or their current status, you'll need to do screening. So often, and I often think of this more as case finding, because typically these are folks that are coming in for a pain condition and are looking for opioid treatment, and you're going to want to do an evaluation to understand what the risk part of the equation is. As you might imagine, people can be very challenged in doing these kinds of interviews. The way I find it most useful to do this is to ask permission. Do you mind if I ask you some personal questions about your substance use? Try to avoid stigmatizing language. Typically, we want to use person-first language. We'll talk more about that a little later in the presentation. We try to avoid calling people as addicts or thinking of them as clean or dirty. We really want to try to use a more medical language in approaching these disorders. You want to be non-judgmental. It's very important to separate your screening from feedback. So if you're asking somebody about their use and they ask you a question like, oh, is that too much or is that bad? It's really important to keep your counsel until the end at such a time that you're going to want to give them specific advice. Embedding the questions in a larger health assessment is useful. Probing about ranges. So if somebody says, I use 2 to 3, it's useful to say, do you ever use 3 to 4? Because people do tend to under-report their use. And then finally, to thank the patient, just that you understand that this can be challenging to talk about and you appreciate their honesty. A number of tools have been validated. Many of them are long and not very practical for a primary care or other medical setting, but some of the newer ones, these single item questions are very useful. For illicit or prescription medication. This one has been validated. How many times in the past year have you used an illegal drug or prescription medication for non-medical reasons? And a positive screen is any answer greater than 0. Now that, remember, it's a screen. It doesn't necessarily mean they have a substance use disorder, but it is an indication that you need to do more assessment to understand that. The National Institute on Drug Abuse has created a modification of the single item screen. So this is the NIDA modified assist. The assist is a longer screening instrument that they have modified to a shortened version. This is the quick screen on this slide. It asks in the past year, how often have you used alcohol, tobacco, drug? So it asks for the different categories of substance use. And again, anything more than never is a positive screen. The assist goes on to look at different categories of drugs, from cannabis to prescription opioids and everything in between. And it looks at both lifetime use and last 3-month use. And then its other parts look at urges and cravings in the last 3 months, whether the person has had health, social, legal, or financial consequences, again, trying to get at some of these DSM categories, whether they've had some issues around role functioning, whether there's any family concern, attempts to control or cut down, again, trying to get at that issue of loss of control. And finally, a question about injection. And injection is often, for me, is a sign that someone has developed tolerance. So typically you go from snorting or smoking to a more bioavailable form, which would be injection, as you develop tolerance and need more and more drug delivered to the receptor more quickly in order to get the effect.
So urine toxicology tests are an added tool when screening for substance use disorder. The majority of time, persons using unprescribed substances will not exhibit aberrant behavior. When ordering a urine tox screen, I try to use that time to open up discussion and ask patients what we will see. Our opioid pain medication agreement allows for random urine toxicology screening, as well as routine screening at specified time intervals based on the patient's stability. We always expect the prescribed pain medication will be present on the toxicology screen. It is important to note that fentanyl and oxycodone will not show up on a routine opiate urine tox screen and must be specifically ordered. Clonazepam is variable with benzodiazepine urine tox screening, so I recommend checking with your lab.
So in summary, opioid use disorder is a neurobehavioral disorder characterized by loss of control and use despite consequences. This syndrome is not the same as physiologic dependence, which can be seen in folks who are using opioids appropriately. Commonly, opioid use disorder is sparked with opioid treatment for a pain condition. And sometimes that treatment can blossom into opioid use disorder. So it's important for you to assess the person's risk for developing that syndrome and using validated tools to screen them for that risk.